and I've titled my presentation Gas Trespass, and my faculty in charge is Dr. Dawn. This is about a 65-year-old lady who is an agricultural laborer from Tirupattur. She presented to us with left-sided abdominal pain for 5 days and an ulcer over the left leg for 15 days. Following trauma to the leg with a sickle while working, she developed an ulcer over the left shin, which subsequently became non-healing. And 5 days prior to presentation, she developed left lower abdominal pain, which was severe, and it was radiating to the lumbar region. She also complained of generalized fatigue and malaise. There was no history of fever, and she did not have any lower urinary tract symptoms. There was no constipation or obstipation, no loose stools. She had one episode of vomiting, which was predominantly food contents. She did not have any comorbid illnesses, and she had history of receiving frequent injections at a local center for aches and pains, and she had history of over-the-counter medication use. On general examination, she was found to be tachycardic with a pulse rate of 115 beats per minute, which was regular, and she was tachypneic with a respiratory rate of 26. She was afebrile and was found to be hypotensing with a BP of 70 by 50 millimeters of mercury with warm peripheries. She was also desaturating to 78% on room air and required 4 liters of oxygen. On general examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pitting pedal edema. There was an ulcer noted over the left leg, which was 4 into 5 centimeters over the anterior aspect of the leg, with the surrounding skin having blackish discoloration, with increased warmth, minimal swelling, and surrounding induration with no presence of blebs. And peripheral pulses were well felt. Systemic examination, her heart sounds were normal with no murmurs. Her respiratory system examination revealed scattered crepitations over bilateral lung fields. On abdominal examination, there was increased warmth and erythema, which was noted over the left flank, and there was marked tenderness in the left iliac fossa. There was no palpably enlarged liver or spleen, and there was no clinically elicitable free fluid. On digital rectal examination, there was a small fluctuant tender swelling, which was noted at the 12 o'clock position. On CNS examination, there were no focal neurological deficits and no spine tenderness. So at the end of history and examination, our clinical diagnosis was a left lower limb cellulitis and a left lumbar probable collection, and she had now presented to us with septic shock and ARDS, and she also had an intersphincteric abscess. Another possibility we thought of was a probable exogenous steroid-induced adrenocorticoid insufficiency, now presenting in an Addisonian crisis. The preliminary investigations revealed an anemia with an MCV of 87 and RDW of 23. She had leukocytosis with 11,300 total counts and neutrophils of 95% with toxic granules. There was thrombocytopenia of 98,000. Her ABG showed a PF ratio of 261. Her creatinine was 1.62. Her urine routine revealed presence of 18 RBCs with fine and coarse granular casts, and the liver function test was also deranged with direct hyperbilirubinemia and hypoalbuminemia with mildly elevated hepatic transaminases. Her 8 AM cortisol was normal, 27.7. Her BBVS was negative, HbA1c was 6.5, and her cardiac echo revealed no vegetations. On further investigations, her CT abdomen showed fat stranding and soft tissue thickening on the left side of the retroperitoneum and the pelvic side wall, extending to the left parailiac region. And blood culture on the second day grew group A beta hemolytic streptococcus, which was susceptible to penicillin and erythromycin. So while in the ward, she started developing new joint pains and recruiting new joints with swelling over the bilateral ankles, knees, and the right shoulder and elbow. On examination, there was increased warmth over these joints with tenderness along with swelling and restricted range of movements. Her shock resolved within the first 24 hours with administration of fluids, and she was initially on noradrenaline, which was tapered and stopped within 24 hours. A proctoscopy was done on day 3, which showed resolution of that intersphincteric abscess. The final diagnosis was that of an invasive group A beta hemolytic streptococcal infection with a left lower limb cellulitis, a retroperitoneal collection, and an intersphincteric abscess. It was now complicated with a streptococcal toxic shock syndrome, fulfilling the clinical criteria of hypotension and multi-organ dysfunction by way of thrombocytopenia, ARDS, deranged liver function test, renal dysfunction, and a probable reactive arthritis. So in this presentation, I will briefly discuss on streptococcal toxic shock syndrome. This occurs as a complication of invasive group A strep infection, and this is specific to group A streptococcus because of the presence of M proteins, which are present on the surface of these bacteria, which is shed into the blood when it's present in a sterile site. And this attaches to the fibrinogen and forms the M protein fibrinogen aggregate, which later on binds to the integrins, which are present on the polymorphonuclear leukocytes, which causes it to adhere to the endothelium and cause degranulation, respiratory burst, endothelial damage, and release of a host of proteolytic enzymes and inflammatory cytokines, which causes capillary leak and tissue damage. And this notably occurs in all age groups, and most of the patients are immunocompetent, and there is no immunocompromised state present. In addition to the mechanism that we just saw, an additional mechanism is that there are present of these streptococcal pyrogenic exotoxins, which are act as super antigens, and they don't need the antigen presenting cells to present it to the T cells, but it directly acts as an antigen, and this acts by cross-linking the MHC class II complex on the antigen presenting cell and the variable domain receptor on the T cell, and this again releases interferons, tumor necrosis factor, and other inflammatory cytokines which cause inflammation. So this acts based on two pathways. This invasive group A strep infection is complicated by streptococcal toxic shock syndrome in about 1/3 of the cases. So although it is rare, when group A strep is isolated from a sterile site, it is quite common to find toxic shock syndrome. Necrotizing soft tissue infection is complicated by toxic shock syndrome in about 50% of the cases, and often no portal of entry is identified, and blood cultures are positive in 60% of the cases. Clinical features are hypotension, tachycardia, fever, or hypothermia, and it can mimic a variety of presentations like arthritis, pericarditis, myocarditis, perihepatitis. So there are a variety of presentations that it comes with. Altered mental status can be seen in 50%, and in 20% it can present it with an influenza-like syndrome. And this diffuse scarlatina-like erythema is present only in 10% of the cases, and they often have symptoms of underlying invasive gas infection, like in our patient who had left lumbar pain because she had a localized correction in that region. So when do we suspect and diagnose streptococcal toxic shock syndrome? In patients who are present with shock in the absence of another clinical etiology. It is diagnosed by way of the clinical criteria, where hypotension is a compulsory criteria and multi-organ involvement of 2 or more of the following should be present. And group A strep must be isolated from a normally sterile site. Management is mainly by management of the septic shock with IV fluids and vasopressors, and surgical debridement. It may often be very difficult as there are deep-seated infections, so source control may be difficult, but whenever possible, early aggressive surgery for necrotizing soft tissue infection must be done, and antibiotics and IVIG are the mainstay of therapy. The mortality can be as high as 79%. Antibiotic regimen of choice is penicillin G along with clindamycin, and the duration of therapy must be tailored to the patient circumstances and how effectively we have achieved source control, and based on the site of infection, and bacteremia must be treated for at least 14 days. The rationale behind the use of clindamycin is that it suppresses toxin production, it inhibits protein synthesis, and also inhibits the synthesis of penicillin binding proteins, and it acts regardless of the inoculum size, unlike penicillin. It is defended by retrospective studies. Although there is a lack of clinical trials, randomized clinical trials, use of adjunctive clindamycin is associated with lower mortality based on 2 retrospective studies, one published in the Clinical Infectious Disease in 2014 and another in the Lancet Infectious Disease in 2020, and that is showing a reduction in overall mortality. Intravenous IVIG acts by passive immunity, opsonization, and neutralizing toxins, and inhibits T cell and inhibitory cytokines. In 2018, a meta-analysis of 5 studies showed that IVIG was associated with 30-day reduction in mortality. However, it is not the best quality of evidence, as 4 of the 5 randomized control trials, 4 of the 5 studies included in the meta-analysis were non-randomized, and it showed a overall effect estimate of 0.46 with a confidence interval lying within the side of 1. Our patient received ceftriaxone plus clindamycin. Her left lower limb cellulitis was debrided. After 7 days of admission, she had to be discharged to a local center due to social reasons, but she showed good clinical improvement prior to discharge. Currently, on following up over the phone, her joint pains have resolved, and she has been discharged from Tirupattur GH after receiving 14 days of antibiotics. So the take-home message in our patient is that we must suspect toxic shock syndrome when we isolate this organism from a sterile site in the setting of hypotension and multi-organ dysfunction. The antibiotic therapy of choice must be a combination of clindamycin along with penicillin G, and adjunctive therapy of IVIG reduces mortality, and the overall mortality can be as high as 79%. Thank you.
Thank you, Kathy. Can I ask Don if you'd like to add your comments to it?
Yes, ma'am. Thanks, Kathy, for the excellent presentation. This patient had come quite sick in shock with multi-organ dysfunction, and we were able to isolate the organism and then appropriately manage her with just penicillin and clindamycin. She responded to it drastically and did not have to use IVIG or and she had resolution of her renal dysfunction and shock. So we just want to highlight the fact that penicillin is the best treatment for group A streptococcal infection, and the role of Clinda, and if they are not responding, then the expert level recommendation for IVIG for such a patient. Yeah.
I'm going to ask Kathy, how long do you give the clindamycin for this situation?
Ma'am, we need to give it for the first 48 hours and then discontinue it, ma'am. So we had given it to her for 2 days and then we continued ceftriaxone, ma'am.
Okay. Just to underline the fact that clindamycin is only for that initial 48 hours for the toxin mopping effect, but after that, we need to just continue the penicillin. Can I request Dr. O.C. Abraham, sir, if you would like to comment on this?
No, nothing, Sudha. Kathy's and Don's comments were covered everything which needs to be covered. Thank you.
Thank you, sir. Any other comments from the other consultants on the meeting? Okay, if there's no further comments, can I ask Janvi to present? Thank you, Kathy, for that excellent presentation highlighting